All right, guys, we're going into the next phase of treatment for a patellofemoral pain patient. So basically, the first visit, we just kind of did some education with them on how to get the initial pain symptoms calmed down. We did some patellar taping to load modulate the contact surfaces between the patella and the femur, recommended a dose of either anti-inflammatories or an icing regimen to get the inflammation calmed down. At this point, they've rested. They should have reduced pain just with normal walking, stairs, getting up out of a chair, that sort of thing. And we're ready to kind of go on to the next phase. So if we think about what we accomplished with that taping technique to give the patella a medial glide, we then want to recreate that same effect with our exercise program, because we're always trying to do either a manual technique or like a taping modality, and then basically recreate that same stimulus with our exercise program that this patient's going to be doing at home. So what we want to do is try to lengthen or release tissue structures in the lateral leg. So if it's on my right leg, I don't know if you'll be able to see this, but the glute and the TFL are what feed into the IT band. I know it's a very common belief that like the TFL maybe has like more of a contribution to the IT band than the glute. The only thing I would say is the glute's a lot bigger. So I personally go after the glute first, and I try to have the patient do, some glute stretching, or I know you can't stretch the IT band, guys, but you can definitely change the amount of mobility between the IT band and the lateral quad by doing IT band mobility drills, is what we're going to kind of call them. So I do think stretching just the lateral structures in the leg, so doing what you would consider a TFL stretch, what you would consider a glute stretch, and then even what you would consider an IT band stretch, even just from a fascial standpoint, lengthening out as many lateral structures in the leg to take tension off that lateral guide wire so that the patella can drift more medially. That's going to help. Then what we want to do, and that's typically, even if they're still having pain, I will go ahead and start with that portion of it, because we're not doing anything that's going to increase compression at the patella. So if they come back visit 2, visit 3, they're still having pain, go ahead and start them on this, where we're stretching out or foam rolling. Foam rolling is an awesome way, doing some lateral quad and glute foam rolling to, again, lengthen out or take tension away from those lateral structures feeding into the patella. In order to increase tension at the medial side of the leg, I am a huge fan of doing certain VMO retraining exercises. I know there's a lot of popular belief that you can't really target the VMO because it's part of the bigger structure of the quad. And I would encourage you to not believe that, because you absolutely can. And it just may be that the folks saying that don't know how to do it very well, but you can certainly isolate or increase the percentage of activation in the VMO, the vastus medialis oblique, in comparison to the other quadricep muscles, if you know how to target that correctly. And I'll post another video of one of my favorite VMO activation exercises as well, just to kind of show you guys how I like to start with that. There's like 3 exercises I'll typically rotate between depending on the patient and their pain response, but we definitely need to do some things to get the medial guide wire tension increased as we're decreasing tension on those lateral guide wires, so that that patella will shift more medially, and we can ultimately like change the contact surfaces for that patient without having to have the tape on all the time. So again, our home exercise program or our long-term program for that patient needs to recreate the stimulus that we're able to produce in therapy. In the actual sessions, I'll typically be doing a lot of medial glides with the patient. I'll be doing a lot of soft tissue work to the lateral quad, where I'm doing this like soft tissue play, and I'm basically really kneading out and giving a medial glide to the quadricep there. Ultimately, again, just trying to take tension out of the inside, add it out, tension out of the outside, and add it to the inside. And it's a very, very effective combination to get rid of pain for these patients. So that's kind of phase 2 in this. And again, it depends on the patient on how well they're going to tolerate some of that VMO retraining. So we may need to like swap the order between this video and the next one that I'm going to talk about in terms of activating the glute and getting less force coming through the patellofemoral junction in general, which is really one of the long-term fixes for this. We may need to start with some of that before we start to go onto the VMO retraining if this is a very pain dominant patient and they're just not able to tolerate strengthening that yet. Because again, if we're trying to do a lot of VMO activation and it's triggering their patellofemoral pain, we are not helping this patient long term at all, because then we're restarting that pain response and that feedback is going to go back up into the brain. We're recreating bad movement memories where the brain is perceiving contraction of the quadricep and compression at the patellofemoral junction as a threat, and then it's going to go back through that guarding cycle and shut down. It's going to kind of go into protection mode and shut down or inhibit the quadricep function around the knee, which in turn shuts back down our VMO. And that's why you don't start VMO retraining in the beginning phases. We've got to get that patient out of pain. We've got to keep them out of pain. Otherwise, the VMO retraining is not super effective. So that's kind of phase 2, and then we'll go on to the next phase after this.